Hello, in this presentation we'll discuss cephalosporins. Cephalosporins are the most widely used antibiotic. They are also a beta-lactam antibiotic like penicillin. They are also similar in structure to penicillins. They are also bactericidal and have a low toxicity. How do they work? They bind to the proteins in the cell wall. They disrupt the cell synthesis and cause cell lysis. And they are most effective against cells that are actively growing and dividing. They also have issues with resistance like the penicillins, and they are susceptible to the beta-lactamases, the enzymes that make them ineffective. And in the first generation cephalosporins, they are destroyed. The second generations are less sensitive to the enzymes, and the third, fourth, and fifth are even less sensitive to those enzymes. So what are the classifications of cephalosporins? You have first generation, such as Keflex, which is still widely used and very effective for skin infections. Second generations, not used so much anymore. Your third generations have really very good coverage. And a couple that you may see very frequently in outpatient setting would be IM Rocephin and Suprax PO. The third and fourth generation are mainly IV meds used in the hospital setting, so we won't discuss those here. The drug interactions for the cephalosporins with the probenecide, the same as with penicillin. It will cause a delayed excretion of the cephalosporins. With alcohol, with certain cephalosporins, it can cause an anabuse-like reaction to alcohol if it is combined with alcohol. And also for drugs that promote bleeding, warfarin, aspirin, possibly even NSAIDs with gastric bleeding. You have to be careful, and you may need to monitor INRs if the patient already has a known bleeding issue. Adverse reactions, always allergy is a big one, and the cross sensitivity if they have a penicillin allergy. Again, the bleeding and other adverse effects such as pain at site of injection. Rocephin injections are pretty painful, and you need to warn your patient that there will be a painful injection and it'll probably hurt afterwards, just to warn them that nothing is wrong and this is a normal reaction. So what are the therapeutic uses? For the first generation, they are widely used prophylactically for patients that are going to have surgery. And again, like I said, they're still widely used for skin infections. They're still pretty effective. You'll find a lot of resistance if you try and use them, say, for UTIs. You don't use them commonly anymore for, say, pharyngitis or otitis. Second generation are not used very much anymore at all. The third generations are still used widely for several infections. They're highly effective against some of the gram-negative as well as the gram-positive organisms. They have less susceptibility, of course, to the beta-lactamases, which make them more effective. And they're able to penetrate the CSF, so that makes them very useful in an outpatient. Even for an outpatient setting, you may have protocols for children to make, if you suspect that they have a serious infection, or if they have any kind of bone infection, just to give them a shot of Rocephin and then get them off to urgent care or ER if needed is a good thing. Sometimes you can give them a shot, have them come back the next day That's a child or sometimes even an adult patient, and see how they're doing, and then make the decision on whether they need to you need to up the level of care for that patient. So they can be very helpful and effective in the outpatient setting. Fourth and fifth generation, like I said, are usually for hospital-based infections, so we won't discuss those here. And that was a brief overview. So our one question here is if the patient is prescribed Suprax, what would you want to teach the patient to report right away?